This is a very important landmark phase 2 clinical trial testing the efficacy and safety of the immune checkpoint inhibitor atezolizumab and humanized monoclonal antibody against PD-L1, the immune checkpoint of the immune system, trying to evaluate whether it affects positively the tumor shrinkage of the patients. And the results of the study were presented last year and showed that there was significant response rate that was compared favorably to historical controls, specifically in patients who had higher expression of the PD-L1, the target protein. The response rate was around 26%, and was around 10% in patients who had lower expression of the PD-L1 checkpoint in the membrane of the immune-infiltrating cells. These results were very astonishing and also saw some signal of longer survival compared to what we expected to see. Of course, it's a single-arm phase 2 study. However, the next step is to try to evaluate which patients may respond better to this treatment and try in the future to come up with predictive biomarkers of response, try to be able to select which patients have a higher chance to benefit. In that regard, we did this study in archival tumor specimens from tumors that were submitted for eligibility in this phase 2 trial. And we did see that there were several biomarkers that could predict response to treatment. Specifically, the expression of the PD-L1 protein in the membrane of immune-infiltrating cells did correlate with response to atezolizumab, to the immune checkpoint inhibitor. And this is something that is not new. We have seen that before. Even in the prior trial, there seems to be correlation between the target expression and the response rate. In addition to that, we also noted significant correlation between the molecular subtype of the tumor based on the mRNA gene expression profiling. And in particular, the laminal-2 subtype appeared to correlate more with response to treatment, which probably has to do with some genetic immune-related signature that is present in the tumor and might predispose it to higher immune surveillance. And with appropriate trigger, thus the immune checkpoint inhibitor, this translated to better response rate. Moreover, and I think very interestingly enough, we saw that the mutational load, the mutational burden of the tumor, as defined based on the number of mutations per length of the DNA in the tumor, the higher the mutational load, the higher the response rate. And this can be explained in immunology terms, because when you have higher mutational load, you may have higher creation of new antigens, some newly formed proteins, antigens that can be recognized by the immune system. And that, of course, can be related to an aggravated response of the immune system against this plethora of new antigens. So the higher the mutational load, the higher the response rate. All these three markers, PD-L1 expression in the membrane of immune-infiltrating cells, molecular subtype, and mutational load, all added independently to the prediction ability. So there were three different independent predictive markers. And down the road, I think further validation of those markers and constructions of some simple, if possible, predictive models can help us out selecting the patients who have a higher chance to respond to those treatments, and of course increase further efficacy and the impact in the patient care in this very challenging cancer. Well, there are many studies that are being conducted, and one of those studies recently completed accrual. It's a study comparing the immune checkpoint inhibitor atezolizumab with chemotherapy in patients with platinum-resistant advanced metastatic urothelial cancer. The results of this study is pending. We don't have the data yet, but it's a large randomized phase 3 trial that are going to answer definitively the question whether immunotherapy or chemotherapy should be given in the second and beyond line setting in urothelial cancer. However, we have to keep in mind that right now, atezolizumab is FDA approved, and there is no FDA approved chemotherapy for the second line setting of advanced metastatic urothelial carcinoma. In addition, there is an adjuvant trial in patients who have undergone cystectomy and they do not have evidence of disease, there is a randomized trial comparing the atezolizumab with observation, trying to evaluate whether if you move this immune checkpoint inhibitor earlier after cystectomy, whether this will translate or not to reduction of the risk of cancer recurrence, and ultimately whether this would prolong survival. These trials, phase 3 trials, are awaited with high enthusiasm to try to, of course, answer more clinical and translational endpoint questions. I think at this point of time, the FDA approval of atezolizumab came without any companion diagnostic. In other words, there is no mandatory method or technique that needs to be used to select the patients. In other simple terms, all comers that progressed on or after platinum-based chemotherapy for metastatic urothelial carcinoma, or within 12 months after the end of perioperative chemotherapy, either neoadjuvant or adjuvant, they are eligible to receive atezolizumab, again, if they have platinum-resistant advanced or metastatic urothelial carcinoma, is a new standard of care. And I think the take-home message of the study that we are presenting here is that we have possible predictors of response that in the future, with further validation, might have higher clinical utility.